All right, ladies and gentlemen, here to give a talk on GSD Type XI, Fanconi-Bickel, is Dr. Terry Derks. Please give him a round of applause. Thank you.
Good morning, everybody. Before we start in this very big, intimidating room with people sitting all in the back, would you mind coming to sit a little bit more closer to the front, to sit together, as you are such a small community? That's at least nicer for me standing here, but also for you to interact. Thank you for doing that. So my name is Terry Derks. I'm a metabolic pediatrician in Groningen, in the northern part of the Netherlands. I should have brought some slides to introduce my city and my country. I forgot to do that, unfortunately. I'm sorry for that. These are my disclosures. There's not a lot of things to say about it. Oh, my slides are not appearing yet, huh? Okay, here we are. Okay. Nothing new here. So these are the disclosures, but nothing with regard to the topic of today to talk about. I would like to start this presentation with two old photos. In the left panel, you see Professor Fanconi presenting in 1940 in the Children's Hospital in Zurich in Switzerland to students, and he was a very famous nephrologist. On the right panel, you will see Dr. Georg Bickel, or Horst Bickel, and Horst Bickel is very famous in the metabolic field also for the first steps in the development of dietary treatment for phenylketonuria. It was a very bright German pediatrician, and he also was fundamental for the first scientific publication on the Fanconi-Bickel syndrome. And that's this paper from 1949. And it was a time where there was no good clinical practice, there was no privacy legislation, so the names of these patients, they appeared full in the paper, and also the pictures as shown. I wonder whether there was informed consent at all. And this patient has been followed in medical literature for several times also later. And I wonder what he thinks of seeing his childhood pictures in medical literature like this. On the left panel in this slide, you would see the pedigree of his family. It was a very close family in a very small village of the Austrian Alps. So there was not a lot of exchange of genes. You may wonder whether the frequency of, let's say, 6 to 8% of those with a genetic disease might have a second genetic disease. Probably it's higher in those areas. But that pedigree shows that in the first patient described with Fanconi-Bickel syndrome, the grandparents of that, or the parents of the grandparents, they were actually siblings. So there was consanguinity in that family. The paper showed a combination of dwarfism, so difficulties with growing, which at that time was mentioned dwarfism, which is not a very nice term to use, I think, and several problems with the kidneys, like diabetes, the loss of amino acids. So that combination with a glycogen storage disease was defined in this paper, very nicely described scientifically as the Fanconi-Bickel syndrome. So what is happening in patients with Fanconi-Bickel syndrome with regard to glucose homeostasis, with glucose metabolism? So let's try to imagine that we are one of those glucose molecules that came out of the food this morning while we were taking breakfast. So it was taken up by our bodies. It was following its route to the stomach and to the intestine. And in the intestine, they need to be taken up by the small intestine. So that's what is happening in the next slide. So these very small cells, let's see, this is showing now, I think, my pointer. So these cells, they are taking up the glucose from the food, following this arrow to the blood compartment. This is a very special situation in the blood compartment, in particular around the intestine, because there is a sort of anatomic regulation there. Because, and that's depicted by a very complex anatomic slide here, there is a preferential flow from the blood vessels of the intestine directly to the liver. So that's what sometimes is called the first pass effect. That's also happening to the food, also happening to glucose. And following the red arrows from the intestinal cell to the blood, that glucose molecule that we were taking this morning by food at breakfast is now finding its way to the liver cells, following these blood vessels here. Here it is taken up, and some of it is stored as glycogen, because you never know when you get lunch. Well, we know today, but we, in previous times where we were hunters, we didn't know for sure. That's one of the reasons why we have glycogen. Check. Besides anatomic regulation, there's also hormonal regulation, because in this area...
Oh, that's me testing the other microphone.
And the pancreas serves as a sensor. So there's also this red arrow to the pancreas. And the sensor of the pancreas is helping with the production of insulin, as you may know. At this moment, while you're listening and while I'm presenting, the intestine is getting empty. So that's why I put this cross here. There's no food entering anymore. There might be some exceptions in the room, but let's say that that's the rule. These cells are becoming more empty. And you see that in this error, I made a small change, because now the liver, as Claudia early was nicely presenting here, the liver is also able to produce glucose. So it can go in and it can go out. And that's because there is a certain protein called GLUT2 that is expressed here in the liver. And in this picture, you can see that the situation of GLUT2 is more complex, because it's not only expressed here in the liver cells, but also in the intestine that we just spoke about, in the pancreas cells, and in the kidney. And this picture might explain why patients have certain symptoms and signs. We're talking about the accumulation of glycogen that can give rise to enlargement of the liver. There are difficulties in maintenance of normal glucose concentrations. There is short stature, as we heard before, and because of the accumulation of glycogen here in the kidney cells, in certain kidney cells, the kidneys may also grow, which is called nephromegaly, enlarged kidneys. And certain cells, they get damaged because of the storage of glycogen and other carbohydrates. And because these cells get broken down, they function less, there is leakage of all types of molecules. That can be detected by blood and urine investigations. So that's why the combination of clinical signs and laboratory investigations might indicate this diagnosis that you can see listed here, the types of metabolite that can be changed. And the treatment has two components. So on the one hand side, the treatment of, well, roughly said, the liver disease by nutritional treatment, and the treatment of the kidney disease, which basically means that we try to add everything that has been lost by the urine, by the kidney leakage. And that's a list of molecules like glucose, bicarbonate, phosphate, amino acids, carnitine might be necessary to be suppleted, and of course also water. So this is basically an explanation of the disease, presentation, what doctors might find with testing, and what are the two main components of the treatment. And that is also indicating why in many centers this is a multidisciplinary treatment with geneticists or pediatric metabolic physicians, with their dietitians who are teaming up with nephrologists in their sites. What do we know about the nutritional treatment? There's not a lot of scientific literature out there. Approximately 10 years after the introduction of uncooked cornstarch for liver glycogen storage diseases, there was a paper of two patients in a UK center. The paper was written by Phil Lee, and he described how the addition of uncooked cornstarch improved growth in these patients. So up until then, the Fanconi-Bickel syndrome was mostly a disorder treated by nephrologists, and it was recognized that even with optimal nephrological supplementation, children didn't grow well. From the 1990s on, there was additional thinking about nutritional treatment, and this paper has made a difference because it was showing for the first time what could be the additional value of uncooked cornstarch in patients with Fanconi-Bickel syndrome. And at that time, it was dosed only twice per day with 2 grams per kilograms. This was another way, there was less experience with cornstarch compared to the situation nowadays.
Yeah,
but
thanks.
it showed
My
that
daughter has
nevertheless,
GSD 5 also.
the growth
And
could
when you're talking about,
significantly improve
exercise and kind of
by
preloading,
this
talk about
relatively
simple
small
carbs.
intervention.
Can you maybe give me details about that?
Then it took many years before a European group under the supervision of René Santer demonstrated in 11 children with nutritional treatment that there was quite some variation in the treatment approaches amongst European centers, but there was one common factor, and that was that certain children grow better under continuous nocturnal gastric drip feeding. And they have demonstrated in that paper 11 growth charts of these children, and I'm just showing one of them as an example. And you can see that this was the index patient in the child, so it took, or in the family, so it took a while before the diagnosis was made. And then at this point here, so this is the height curve, and this is the weight curve. So at this point in time, so that was approximately at 6.5 years of age. Continuous nocturnal gastric drip feeding was started, and you see an increase in height on this curve, also an increase of the body weight. But then, for reasons that they did not explain very well, it was stopped again, and at the second occasion it was started, and it was stopped again. 11 of these curves were shared in this paper, emphasizing that nocturnal gastric drip feeding could be helpful to improve growth in children with Fanconi-Bickel syndrome. In these times, the diagnostic field also drastically changed because we got exome sequencing. So we were able to investigate for many inherited diseases by a single genetic test. And that also gave rise to more information about the genetic testing in different patients with Fanconi-Bickel syndrome. And that was nicely illustrated in this paper by German physicians who summarized several patients with the Fanconi-Bickel syndrome. And they demonstrated that there's also a group of patients who seem to have milder disease phenotypes than those patients that had been known for since 1949. That is demonstrated in this table. You can see that these patients, they had, there was absence of hepatic problems, and there was, well, to summarize, only very mild glucosuria and perhaps mild renal involvement and loss of different components in the urine. And this is a very important concept to keep in mind, they argued in the discussion of their paper whether you wouldn't call it a GLUT2 deficiency rather than all mentioning the patients as Fanconi-Bickel syndrome patients, because this original phenotype was much more severe, involving more organ systems than those relatively mildly affected patients in this paper. So this was basically what I had in mind as an introduction on the topic of the Fanconi-Bickel syndrome. Perhaps I could pause now and see if there are additional questions, because in the second part of my talk, I would like to focus a bit more on the drug repurposing and the use of SGLT2 inhibitors and Jardians in particular. Are there any questions from now?
And another question is,
If not,
fruit,
we just move on. Yep.
Sweetener appropriate for 1A?
I will start with a very busy slide to give you some historical context, an overview on the timelines of this drug repurposing story. And drug repurposing, for those who are not familiar with this term, it means that there is a category of drugs that has a certain indication where doctors found that you could use it for another indication. So repurpose it, give it another meaning, so to say. And it was thanks to, very important fundamental research by a Belgian group of researchers from the De Duve Institute, Maria Vera Cunha and Emil van Schaftingen, and they explored the pathophysiology of the neutropenia and the neutrophil dysfunction in GSD1B. And that was very important also in our thinking for Fanconi-Bickel syndrome. I sometimes like to make the connections between different GSD subtypes to see if there are common lessons to be learned. And in this case, as Maria and Emil had investigated the pathophysiology in more detail, they also came with a possible solution, and that was the use of a class of drugs, medication, that up until that time was only given to patients with diabetes. And that sounds a bit scary. Drugs given to patients with diabetes who have high glucose concentrations that automatically will bring down glucose concentrations. However, could you give that to patients with glycogen storage disease type 1B who have difficulties with maintenance of their glucose concentrations at all? To many of us, that sounded as scary and a dangerous thing to do. Although there were reasons to try this, because there were not that much alternatives for GSD1B patients at that time, and there were patients who were really suffering a lot. In some occasions, we were standing with the backs against the wall. And I remember once that Saskia Wortmann called me when I was sitting in the train traveling in Germany, and she was discussing one of her GSD1B patients. And when I told her everything that I basically knew, in the end I told her, okay, I remember that I spoke with Maria and Emil some time ago, and they came with this solution. I haven't been able to try this yet out, but perhaps this could be a possibility for your patient as well. I had a similar conversation with Johan van Hoven, and together we decided to try this out in the patients in whom we were suffering the problem and in whom the standard of care clearly wasn't enough. That was more or less in 2019 that we started this treatment, and we published it in 2020. The protocol was already shared at the International GSD Conference in Brazil in November 2019. So more colleagues were interested in doing this and were convinced about the ideas behind it. And by sharing the protocol, we also ensured that a large group of colleagues were about to treat patients in similar ways, and that we could collect information and experiences about this treatment. And that started in this green period of time, which was the COVID pandemic. A lot of things happened there, but also webinars. We learned to organize webinars, and we learned as healthcare professionals to share this information. And You could also say that this was not really according to the professional standards, because at the time that I was already talking to Emil and Maria, they said that there was a group who was about to develop a randomized controlled clinical trial. That trial is still on clinicaltrials.gov, but it still hasn't published data, which means that if you follow the traditional trajectory according to the rules that we have learned, it might take very long. And if we would have done that and if we would have waited, many patients would not have benefited from a potential treatment. And that's the dilemma that we are very often in, that there is a reasonable way to do things, and there is an official, formal, regulatory way of doing this. And sometimes there is a lack of alignment between those. So we decided to do it differently. We have published, in collaboration with many, over 20 papers about the use of this class of drugs, which are called SGLT2 inhibitors. And I will explain a bit later why SGLT2 inhibition, what that would mean. But this class of drugs, the most important example is Jardiance, and most of you will know that drug. Why was it important for us to publish about it? First and most for all, for patients to do something meaningful. But if you don't publish about it, the publications are helping us in negotiations or discussions with regulators. And we started that in November 2022 to obtain reimbursement for this treatment, so to make it accessible for all patients. And this organization, the National Health Institute in the Netherlands, they had to study more than 1.5 years on these files. And luckily in August 2024, they approved it. In the meanwhile, we also added the documentation to the pediatric online repository for the use of drugs. And by publishing in the medical scientific literature and by adding this to the repository, it was also clear for the regulators that there was no way to avoid this. They had to support it. Also because we were able to demonstrate that this is a much cheaper treatment than the treatment in GSD1B with Neupogen. And so in the end, they were convinced. But to be honest, we knew this already after 4 weeks of treatment with the first 3 patients. This is a long introduction about the different disease, but this learning curve was crucial to understand why at a certain time we were also wanting to trial this in patients with Fanconi-Bickel syndrome. And for me, something very important changed by getting to know a new family in our area. So the first boy, this was a family from Eritrea, so they were immigrants. Their first child, was diagnosed in the first weeks of life in our area. We followed the kid quite a long time, and at a certain time he was really developing differently than from what we knew of Fanconi-Bickel syndrome patients. And we heard it before that from all patients with a genetic disease, probably 6 to 8% has a second disease. And I'm pretty convinced that he had a second disease, and unfortunately he passed away on New Year's Eve in 2029. Shortly thereafter, the COVID pandemic started, and in this green area, the little boy or the family got 2 new children, 2 little boys, both with Fanconi-Bickel syndrome. And we started following these little kiddos as well. And every time, of course, seeing the children, talking to the parents, a question that was always there was, are they behaving in a similar way or differently from their older brother? Of course, we were fearing that. And there is a mother's feeling and a father's feeling, and there are doctor's data and feelings, and we tried to bring that together every time. And that also made us aware of the fact that some of the kidney functions seem to be very different in one of the little
Say it again?
brothers versus the other brother. And that made us think again, what could be the possible explanation
as I was
for
saying
that?
If you're not
And that
taking
was a
3-4
topic
gram
that
per
we
kilogram of
discussed in more
protein,
detail with
you may not
Sarah
see a change
Grunert
in your
and
BUN in
René
that
Santer. So
context.
these are
If you
two
take 2 to
German
3, you probably
colleagues.
won't see as much of a change.
And we thought,
But for
okay,
GSD1, if you do that, you will
probably
see a lot
something
of
is
metabolic
happening in
change.
these kidney cells differently in the 3 little children in one single
Hi,
family.
I have
But
GSD1B.
they all have the same
My
mutations
question
in
is,
GLA2.
How common is
What might
feeding therapy?
explain
Because
differences
when I grew up
here
in the 90s, it didn't
in
even
this
exist, and it still affects
at the
how
level
I
of the
deal with
kidney,
food
of
now
these
because,
proximal tubular
certain textures I don't like
kidney
eating because
cells.
they're too chewy. I don't like rice. And
If you watch more
it takes me a long
closely
time to
what
eat
the
still, and I'm still
GLA2
not a
protein
foodie,
is
so
doing, it
they're
is
like, "Why does it take you
allowing
half an hour to eat your dinner?"
glucose
I'm
to
like,
leave
"Oh,
the cell
because
again.
I didn't have any
But
fear
before
feed
being
when I
able
was
to
younger.
leave, it first has to enter. Then we saw that, okay, this is SGLT1. Perhaps that's an explanation. But SGLT2 could also be an explanation. And that made us realize that, in theory, if you could block it, or if there would be differences in transport rates here over one of these proteins, then perhaps there would be less storage of glucose, less storage of glycogen, and other small polymers of glucose molecules, small glucose-alike components. So, and if there is less storage, then there is less of a problem due to this defect that exists in the 3 siblings. By saying that, implicitly I'm saying that what would happen if you would block SGLT2 pharmacologically? And that was the way of thinking behind using the same drug for another glycogen storage disease, learning or based on the lessons learned in GSD Type 1B. And our hypothesis was that by blocking this protein by Jardians or whatever would be available in which country, we would have less of the glucose accumulating. You see that glycogen becomes smaller, so hopefully less accumulation of that glycogen. This is very difficult to measure in the laboratory, but we thought we can measure that with our patients, because if this would work, what would be meaningful for the patients? Well, if there's less damage of these cells, there would be less leakage by the kidneys.
Oh, there we go.
There would be less
Jackson has a
glucosuria,
physical
there would be
therapist, and
less
he's been with
loss
her
of
since he was 6 months old. But I
salts,
will say that
amino
the
acids,
biggest thing that helped us
carnitine,
was, like,
and there would be
exposure
less
therapy.
need
So they did
to give these
something
supplements. These supplements that very often give rise
it
to
was
abdominal
kiss it,
cramping,
lick it,
nausea,
rock it.
or diarrhea. So
And
there are
you
all
start
types
with
of
just, like, touching things to your mouth to get
side
that
effects
exposure therapy,
known
and then when you feel
that are very
comfortable,
often also a
lick
reason
it,
for our patients
and
not to
then
use it
his
at all.
favorite was
So
rock
there
it,
are
where you take a
compliance
bite and
issues.
you spit it out.
And in my
So,
experience, the
like, he
biggest
really loved
compliance
that,
issues
and
occur
it helped
with
get him
children in
past
puberty.
quite a few of his
Okay.
like,
But
he
these
was put on a feeding
2 little
tube for
killers
some
from that
problem. He
family,
didn't have any of
where we
that
started the way of
initial
thinking with,
auto-learning of how
when
to
I
feed.
shared this idea, okay,
So
we
we
might
struggled
start
a
with
lot
an
with
experimental
getting
therapy,
anything
and
to touch his
nobody in the
mouth.
world is yet
And
very
those
convinced
things
about it. So
really
we are
helped
really
him,
in the path
he
of
was
making this happen for
until
another
for,
GSD type. I try
don't
to
know, the
explain it
first
as much
5
as
years of
possible
his life,
with
he didn't swallow
interpreters,
anything.
etc.
And,
To a family who had lost one of their
but we
children
would
with
let
the
him
same
lick
disease.
everything.
You can
So
imagine
we'd
that
go
they
to
were not
therapy
very
and
happy
we'd
with,
get, like,
with a new idea.
bacon and eggs in the
So the
morning
father
and
said something very
lick
wise
it.
to
He
me.
was
If you can
totally
demonstrate
chill.
it
It was, like,
with
his
another
favorite
patient,
thing. Like,
you
he
can come
gets
back
to
to
lick the
me.
salt off. So
And that's
I
what we
would
did.
say you could probably do
Because
these kinds of things
the
on
other
your
patient
own
that I was
at home.
following, that was a
And then
patient in
once you find a
puberty.
feeding therapist,
And that
he'll give
boy,
you
at the
goals.
time that
So,
this
like, this
idea
week work on
entered
this,
our heads,
you
he
know,
was a little bit
by the
over
end of
14
this amount of
years,
months, we want you to have
and he
10
is
new
the,
fruits
he was
that you've
he still
tried.
is, to be honest, the type of
I would
person
say
that would qualify to the
it really
most
helped
traditional definition of
our situation
puberty.
for those
He was not saying what he was doing, and he was not doing what we were asking him to do. So very hard to follow that category of patients in general, but in particular with glycogen storage diseases. But I explained to him that this was, of course, not, I didn't know for sure whether it would work at all, but there would be a possibility that this would help him to grow better. There would be a possibility that we wouldn't need these nasty, horribly tasting drugs that were prescribed by my colleague from the nephrology department. So there were short-term possible benefits. So we started the negotiation about that. The only thing that we asked him to do was to help us to find this out together. So we hospitalized him, and we did all the measurements. And before that time, we designed a protocol together with Sarah and with René, because they also had some patients in mind. But we started with him. And after we knew that this was going to happen, we also started with the 4 patients in Germany. They were adults, so that's different from the situation with our families. And then we came back to the father and the mother of the 2 little kiddos, and they were convinced, and they also agreed with starting this treatment. And that's the story behind the publication that we submitted 2 years ago. What did we find in terms of efficacy and safety? We followed the children very closely with continuous glucose monitoring in the hospital because we didn't know what to expect. But the CGM readings, they were very acceptable to our opinion. There were no symptomatic hypoglycemias, also because our dietitians were involved, obviously. We also included our pharmacist, the hospital pharmacist, because in the end, we wanted to add this case to the already existing case with the regulators in the Netherlands to demonstrate that this is a cost-saving intervention as well. All these supplements, they are extremely expensive. And we calculated that we were saving approximately 16,000 euros per year, which is not a lot for insurance companies, but it is a lot for families like this one. So the conclusions about 7 years of drug repurposing, so reusing the diabetes drugs for ultra-rare hepatic glycogen storage diseases, it's a wonderful experience, to be honest. It is not only according to regulations and rules that we have learned as physicians, but we are searching for pragmatic solutions for questions that are not solved by others, so we have to deal with it together with families. We've seen that it is helpful to use this drug for the extrahepatic complications in GSD1B for the treatment of neutropenia and neutrophil dysfunction, with all types of ideas that now can follow that we never had time to think about because it was a difficult disease to treat. It still is a difficult disease to treat, but SGLT2 inhibitors are, a good addition to this. For the Fanconi-Bickel syndrome, the mechanism is completely different. The drug is the same, but the way it acts in the body is different, or at least how it interferes with the development of symptoms and signs. So in Fanconi-Bickel syndrome, it is an appropriate way to try to attenuate the renal proximal tubulopathy. We see differences between patients. We do not yet understand that. And of course, we are thinking about how we can connect with others, how we can exchange experiences in a similar fashion as we did a few years ago for GSD Type IB. This is fun to do. It is a very fast way of getting a drug available for patients. And it is valuable because in a short time, doctors can see that it is meaningful for patients and families, and that is stimulating a lot also to bring this to the next steps. It's cost saving, that's important for others, but sometimes also for the families. And it is nice to collaborate internationally and to make big impact to reach large numbers of patients in a relatively short time. But we also learned that this is really a different business from the reimbursement issue. If you put it in perspective and compare to the other international collaborations that have existed over the last 15 years, clinical trials where GSD sites have collaborated. You
I have a type
probably are
7.
aware
Yeah, I
of
was
the
wondering
GLIDE
what
trial.
would be your
The
dietary
preparations already have started shortly after 2010, I think, with the company VitaFlow. And different sites collaborated in this trial that was published, I think, only 2 years ago. Well, many of you are aware of the gene addition trial, the AV8 gene therapy for GSD1A. The company is Ultragenyx, and up until now, approximately 60 patients worldwide have been treated. But the preparations already started with the clinical advisory board in 2016. But the fundamental research part of that is from the previous decades. It started already in the 1990s. So a long time of
my son's
scientific
type
work
3.
before it is
So he plays
coming to the
baseball,
patients. But the big
and
challenges
we
will
do give him a
be
shake
to
before,
assess
but I
efficacy
feel like
and
I'm
the
just
discussions about
realizing it's
reimbursement
not,
and
like,
getting it
enough.
available to a larger
Baseball is
group.
kind of strange because it's like 1 minute you're
You also see
doing
some
second,
trials
and then
that
next minute you're on the
seem
bench
to
waiting
have
for
stopped
at-bat,
without
right? So,
disclosing any
like,
reasons. That also happens in this reality.
when I watch
And that
him
contrasts even
and
more
a
with
ground
the
ball gets
academic
hit,
drug
like,
development.
sometimes it looks
So
like
for
he's, like,
the
in
SGLT2
water, right?
SGLT2
Kinda like
inhibitors
slow
in
motion.
GSD1B, we have reached out to
and
hundreds of
so I'm just
patients
curious,
worldwide
like,
that
when
are
it comes to the
benefiting from this
simple
treatment.
part,
And according
like,
to the
if he
numbers
needs
that we are
something,
collecting now in the international
how
collaboration,
much?
we
Because
are
it's not
aware of
consistent movement
approximately
like
60
swimming
patients
or
with Fanconi-Bickel
basketball.
syndrome that are now being
How
treated
much
with
and
Jardians
how quick
or an
does it
equivalent.
act?
And this also
If
makes us
he's
very
not
proud because
getting that
we are
immediate
basically doing
energy
this without any
in
funding.
the moment.
With funding, it would be even faster, but how much more contrast would you need with sponsor-initiated clinical trials and drug development? This brings me to the end of my presentation, but not before announcing that next year the International GSD Conference will be hosted by my colleagues and I in lovely collaboration with many scientific and patient collaborators. Please take notes of the email address if you would like to be informed on time about when the registration opens and when abstract submissions are possible. I thank you very much for listening to me, and I'm open for additional questions. And thank you for being here again. And I hope that together with me, you will be supporting the Dutch team who will start playing at 1 o'clock. Thank you very much.
Thank you very much, Doctor. All right, any questions so far? Anybody?
Right.
There we go.
That was a lovely story, and it's a testament to the success of collaboration and just thinking outside the box.
And then, so
Can
I
you
was a little
tell us
surprised,
little
like,
bit more
to
about
hear,
the
like,
dosing
candy
and how
might not
you
be
manage that,
enough,
because I saw that there
right?
was
So
an escalation.
we've
I
been,
know that our
he's been
nephrology colleagues
drinking
always push back
G2
when we want to use
Gatorade,
it if there is
but maybe
some
it
element of
needs to
kidney
be
failure.
more like regular Gatorade, or I don't know.
Because we were concerned of the safety issues, we had in mind to do a very careful dose escalation. So we started with the lowest dose possible. And for empagliflozin or Jardians, we had capsules of 5 milligrams available. And that was appropriate theoretically for the first patient that I was treating with GSD1B. In theory, that would have been okay, but just with all safety concerns and uncertainties associated with this drug, I asked the pharmacist to make a suspension of it to start with even lower doses. And because I didn't know what to expect, we were when I discussed it for the first time, it was in May. This was a Turkish family. They were dying to go back to Turkey to visit family. And this is the only time in my career that I told to a family not to go on holidays. Instead, they spent the holidays in Groningen, in our hospital, because we didn't know what to expect. And I didn't want to be too pushy, too fast with the treatment. So at that time, with the collaboration also with the hospital pharmacist, starting low doses, with the use of this suspension, we very gradually titrated, because at that time we didn't have any safety data at all. Still, we do not have a lot of pharmacokinetic data in children about these drugs, because the experiences we had up until then was with diabetes patients and in adulthood. So this made us very careful. I think we've now more experience, so I would be faster now, probably starting easier with 5 milligram doses. On purpose, I would start in the morning, because you better see what it's doing instead of dosing it in the evening, in the night, because the peak doses will be reached within a few hours after the intake. But we also realized that in young children, you need to be careful, not only because of the lack of experience, but also because of the associated hypoglycemia risk that seems to be higher in young children. And also these drugs, they are broken down differently in young children compared to adults, or at least the systems that are responsible for the breakdown of these drugs. They are very different in young children compared to adults. And that also made us realize that initially we had to be very careful. Is that a bit an answer to your question? Yeah.
To follow up on that question, have you only used empagliflozin, or are you using other drugs in the same class? Do you think it's a class effect? Because I mean, for diabetes purposes, they do vary some as far as the different efficacy and the management of other complications of diabetes. So do you think this is a class effect in general, or do you think there would be certain drugs in this class that would be better than others based on your experience?
Initially, we were very pragmatic. At that time, if I recap that correctly, there were 8 SGLT2 inhibitors, of which there were 4 registered in the Netherlands at all. And for the first publications, or for the first treatments, we wanted to use one drug that was available in the majority of the country to make the collection of experiences and as careful as possible. The exception were Italy and France, where dapagliflozin was registered instead of empagliflozin. So that's the explanation why in some countries different drugs have been used. But there was not a very big rationale behind it. But theoretically, you might be right that if there is a lack of treatment efficacy, you could try one of the other drugs in the same class. And if I remember correctly, one of these drugs, it's a combined inhibitor, which might also inhibit SGLT1, which is registered in India, for instance, but not in the Netherlands, so I wouldn't get access to that one. I'm imagining how our hospital pharmacists would react if I would come with that solution. Sometimes they do not really seem to like me, because as far as I know, hospital pharmacists, is there any hospital pharmacist in the room before I continue? Okay, I will be very careful now with what I say. But what I mean to say is that all the pharmacists that I know in Groningen, at least, now they seem to be able to follow the rules very carefully, but they do not always seem to be able to explore with us the additional solutions that might be there as well.
Because they weren't taught to think right.
I hope that everybody can hear that.
The new students are being taught to think black and white and not be willing to
Hi, I have type 2, Pompeii. My question is more about insurance.
We are never too old to learn.
There were some comments about access, and I
Very good.
know in
Thank you.
our community at
Terry,
least, a lot of people
You had
seeing
CGM
their
data.
nutritionist is not covered.
Yes.
Did you notice
Fortunately, my
any
insurance,
difference
it
before
is.
and after
But I know a lot of
starting
people
EMPA
cannot
in
see
postprandial
nutritionists because it is not
elevations for these
covered.
patients?
Um,
Any
What
improvement
would
of
you
that?
recommend to patients?
We used it
as a
basically
way to advocate for
to
yourself
identify
if this service
non-clinically
is not covered
relevant
by your
or
insurance?
clinically
This one or
relevant
the food one that was talked
hypoglycemia, so no hyperglycemias but
things that are very important
hypoglycemias.
to all
And
of these GSD.
in my patients, we could make very small adjustments,
diagnoses. What would
adding
you
a
recommend to people so
few
that they
more
can
Uncle cornstarch
this
to
service
prevent this
covered,
from happening.
or
So that was
how
the
could they
type
get
of
it maybe
titration
at,
that we did in
a
our
lower
patients. So
cost?
the morning doses of cornstarch and the timing of the empagliflozin versus the Uncle cornstarch dose, that for that purpose the CGM was very helpful. I have not systematically analyzed all the individual readings for this purpose.
And the other question I had is regarding calcium and phosphorus metabolism. So you mentioned being able to decrease the supplements, but in that regard, did you notice any trends?
Yes. So the pH remained normal. Also now we are a few years further. pH remains normal. Bicarbonate concentrations in blood, because we are following up them more frequently than we used to do, just because we wanted to be sure that we are not harmful by withdrawing any of these supplements. But up until now, all the lab values remain normal. Alkalic phosphatase remains normal. Vitamin D levels remain perfectly in range. They are growing well. So for the young children, we seem to have a window of opportunity for this treatment. But as you can see from this scheme, already in this scheme, you can see that there are alternative ways of glucose to enter these cells. So we are very aware of the fact that this might be a temporary effect. We have to find that out.
Terry, I'm sorry I was a few minutes late, but I just wanted to congratulate you on this. Two quick questions. The impact on rickets. Like, I don't know if you showed those, like, were there changes in terms of X-ray findings? And then the other one was, what is the maximum dose that you have used in terms of EMPA with these patients?
We are following up also with X-ray pictures, and that is also positive in this way. So we don't see any decremental or negative effects there up until now. And that's, I think, also reflected in the growth charts too. But the development follows the same direction up until now. And with regards to the maximum dose, that's a good question. I wouldn't know that. I think that most of our dosing information has been based on the pharmacodynamics that are of interest for the treatment of diabetes patients who are treated with multiple drugs for this purpose. And we have to establish that for this particular indication, keeping in mind that a subset of the Fanconi-Bickel patients later on will develop diabetes.
I actually meant it for the radiographic. I was looking at it more as an improvement. And so if you used a quantitative marker like has been used in clinical trials, like radiographic impression of severity and of change, that would be a great objective way to show how the therapy has worked.
You're right. That's true. And the data are available, but I didn't show that, and I haven't collected in a systematic way yet. Yeah.
Anybody else? All right, how about a big round of applause for the doctor? Thank you very much for your talk.